Chapter 31, Section 5. Here, we're going to be looking at meningitis and what is referred to as meningococcemia. Okay? Meningitis is anything that ends in itis means inflammation of. Meningitis means inflammation of what prefaces it, the meninges. Remember, the meninges are the layers, Duramater, Pia mater, arachnomater, I think it's arachnoid, whatever. It's been a while since A and P for me. But anyways, it's the three layers of coverings that cover our central nervous system. It acts as the blood-brain barrier, or part of the blood-brain barrier. It keeps everything out. Well, if you stop and think about it, there's only so much room in your brain, in your skull. Your brain takes up the majority of it, and you got this thin layer of meninges. The meninges swell. Well, they're going to take up more volume in your skull, down your spinal column. They're swelling up. What's going to have to give up space? What's going to have to give up volume? Your brain, your spinal column. So meningitis, the way it causes damage is compression, putting your brain under pressure, putting your spine under pressure. We see that meningitis can be caused viral, bacterial, fungal, and protozoan infections. This is everybody. Everybody can cause this. And it turns out that some are worse than the others. You know, bacterial infections are easy to treat, but LPS, the endotoxins, any bacterial proteins, exotoxins, things like that are there, stay on the meninges, can still trigger and maintain the meningitis long after the vegetative cells are gone. Same with the fungi, same with the protists. Viruses are the harder to treat because we have fewer compounds that we can use as antivirals. So it's going to be harder to treat from them than it is the vegetative cells. But once the viruses are gone, meningitis then quickly, resolves over a few days. Whereas bacterial, fungal, protists, you get rid of the vegetative cells, but you still got the remnants there, which will prolong it much longer. The meningitis long after the infection is gone. One of our chief bacterial causes for meningitis is Neisseria Meningitidis. Okay, we saw Neisseria Meningitidis mentioned in section 1. It's going to be an upper respiratory thing, sinuses, and because it has its abilities, we're going to see that this gram-negative obligate aerobe is going to be able to penetrate mucosal tissues, bone, whatnot, through the blood and stuff like that, and get to and settle on the meninges. We see that once the infection starts, and I'm not just talking the presence in the sinuses, I'm talking it's now gotten into the tissues, you're going to see tissue destruction. You're going to begin to see gangrene and whatnot set in. Presence of in the tissue starts remodeling. The remodeling of the bone, remodeling of the mucous membranes covering the bone, the epithelial tissues covering the bone, they start all first swell up because of inflammation, but that prolonged inflammation over time, here we're talking days, weeks, maybe even months, causes the bone to withdraw, change its shape, allowing for access deeper into the tissues. You start to get coagulation of the blood. Blood flows in, blood doesn't flow out, stuff collects, cells start to die, cells die, tissues die, remodeling sets in. Not a good picture. Now, if you get Neisseria meningitidis elsewhere, okay, here you get Neisseria meningitidis, it went bacteremic, okay, penetrated through the tissues, into the capillary beds, boom, you have bacteremia, Remember, emia, blood, bacteremia means bacteria in the blood. It settles out in capillary beds elsewhere. This small child, this patient here, has the bacteremia all over its legs. You can see the black tissue, death, necrotizing. Now, what's different here than the necrotizing fasciitis? This is relatively superficial. These are the capillary beds of the skin. So this is skin. Pretty good chance that with debridement, the underlying adipose tissues, muscle tissues, bone, and all that below that will remain healthy. So that's the difference between this and the necrotizing fasciitis we saw with Streptococcus pyogenes. That's full depth that needs to be surgically removed down to the muscle, and even in the muscle, maybe even down to the bone, if not the complete limb. This, not so much. Epidermis, dermis, or epidermis definitely, dermal layers, maybe adipose layers. Is the thickness we're talking here. Now, as it's going in the blood, as it's getting remodeling and it's causing bone membrane remodeling up in the sinuses, getting into the capillary beds, bacteremia going everywhere. Some of the places that it can settle out are the capillary beds of the meninges. So what we just saw on the last slide, think that, but on the meninges, but not as much necrotizing, necrotized tissues, because the meninges are going to swell, and that's going to impede blood flow in, things like that, and you're going to get feeling that a lot faster than the tissue degradation that you would on a limb. You see, this is usually occurs epidemics. One person has it, there's going to be other people around. May not progress to what we saw on the last slide, or meningitis, but if one person has it in a group, lots of people are going to have it in that group. It's just one person is showing symptoms of severity enough that they went to a doctor, which is why nowadays you see that meningococcus is one of the vaccines. Meningococcal meningitis is what they'll call it also. They'll have you go and get the vaccines for it before you. I know Lindenwood, I think, also does that. Normally, this is going to hit school-age children up to young adults. So, about elementary school up through high school level is more often than not. Why are we saying you got to have it for college? Because of dorms. You're going to get a lot more people in a lot more close proximity in the dorms than you normally did junior high school level. Airborne's typically, the transmission's typically airborne. I cough, you breathe in. Boom. Have there been other routes? They think, but they haven't been able to show it as a great spreading mode of transmission. So normally we talk about meningitis, meningococcemia. We just talk airborne. Treatment, penicillin still works. Penicillin, because you can't use penicillin because the strain you have in you is resistant or you're allergic to penicillin. There are other antibiotics out there. If you're just positive for it or you're an exposure, yeah, here's some pills. If it's to the point now where you've got meningitis and one of the clinical signs of meningitis, signs of it is a patient who cannot move their head. The meninges have swollen so much that the neck has now become stiff. The back is now stiff because the meninges are swollen. They're compacting what should be a very pliable, spinal cord. Everything's now locked in there, overpressured. They're telling you about this extreme migraine level headache, and the whole time they're not moving their heads. They can't. Normally, as you're watching me do this, you can touch your chin, unless you're fat like me. You can touch your chin to your chest. You can move it, twist things around. But if they have meningitis, they can almost force it forward a little bit, almost force it, hurts to turn their head because of that compression where those meninges are swollen up. But at that time, you're putting them in the hospital because you don't know bacterial, viral, fungal, whatever, broad spectrum antibiotics that they can handle, as well as acyclovir, antiviral. Until you know whether it's bacterial or viral, you're going to treat for everything.